Good morning, all. Today, our topic for lecture is Anchorage. Anchorage in orthodontics is one of the main topics which is the foundation on which we plan our treatment. I have incorporated this picture of the city of Anchorage in Alaska just to show that it is also the name of a place in US. Now, coming to the simple definition of anchorage. Anchorage is a secure hold sufficient to resist a pull. That's the simplest definition given by Webster's. So you all know, you before encountering dentistry, you all have come across the term anchor or anchorage. What comes to your mind is the image of a ship calling upon a port and requiring an anchorage to be safely secured to the harbor. So, what is exactly anchorage? So, why a ship needs an anchorage at the shore? Because the ship, once it's reached the shore, it should not drift away by the waves of the sea. So it has to be safely and securely held by an anchor. So anchorage, by the Webster's dictionary, it assumes the definition: a secure hold sufficient to resist a heavy pull. So anchor is a rigid point of support, a source of stability. So the simplest definition of anchorage from the orthodontic perspective was given by Prophet. According to Prophet, in his book Contemporary Orthodontics, anchorage is defined as the resistance to unwanted tooth movement. That's the simplest definition given by Prophet. According to the text written by the authors White and Gardner, anchorage is the site of delivery from which a force is exerted. So, from the orthodontic point of view, how will you manage the anchorage? It involves restricting the movement of one group of teeth while facilitating movement of the other teeth. We all know that we are encountering patients who presents with the complaint of protrusion of teeth. So what is our treatment goal? To bring a new self-confidence to the patient by reducing his or her protrusion. So we want to facilitate the movement of the anterior teeth while restricting the movement of the posterior teeth. Successful anchorage management is the key to successful orthodontic treatment. It also defines the relationship of the tooth movement to the force. So when you apply a force, what is the drug used in orthodontics? The drug used in orthodontics is a physical entity rather than a chemical one, which is nothing but the force. So when you apply a force to move the teeth, you should concentrate the force needed to produce tooth movement where it is desired. And we all know the Newton's third law states that for every action, there is an equal and opposite reaction. So once you concentrate the force needed to produce a tooth movement where it is desired, the reactionary force has to be dissipated over as many other teeth as possible, keeping the pressure in the periodontal ligament of the anchor teeth as low as possible. So if what will happen if the same amount of reactionary force is there in the posterior teeth, they also start drifting away, and maybe you will end up with a space closure, but the treatment will not be as successful as you have desired. So let us explain that concept with this diagram. In this diagram, you can see that the first premolars have been therapeutically extracted for the purpose of orthodontic treatment. So in this picture, you can see that some values have been assigned for central incisor, lateral incisor, canine, the posterior teeth like the molars, first molars and second molars. The number of the value of that number in the posterior teeth are much higher when you compare it to the anterior teeth. What does it signify? It is given by a person called Freeman, and he termed it the Freeman's Anchorage value. So you have this much amount of root surface area. The number signifies the amount of root surface area the teeth is having. So the optimum orthodontic force level for movement is the lightest force resulting and the resulting pressure that produces a near maximum response. Any force greater than that is equally but would be unnecessary, traumatic and stressful to Anchorage. So you should keep, or in the biology of tooth movement, you have studied that we should apply light continuous forces, which is the optimum force. So again, the same diagram has reappeared. It is nothing but the Freeman's Anchorage value diagram given by Freeman. It roughly signifies that the anchorage value of any tooth is roughly equal to its root surface area. The number that has been denoted there signifies the root surface area of the teeth. In this picture, you can see that the second premolar and the molar in each arch is approximately equal in surface area to the central, lateral, and the canine. This was given by Freeman, and it's called the Freeman's Anchorage value. Now, coming to the sources of anchorage, the anchorage can be classified according to the sources. Primarily there are two sources of anchorage: intraoral and extraoral. Now, first, let us take a look at the intraoral sources of anchorage. Intraoral sources of anchorage comprises of teeth, alveolar bone, basal bone, and musculature. Which are the intraoral sources of teeth? It is again decided by the root form, size and number of roots, root length, inclination of tooth, ankylosed tooth. So, the factors influencing the intraoral source of anchorage like teeth are the root form, size and number of roots, root length, inclination of tooth, and ankylosed teeth. Another intraoral source of anchorage is the alveolar bone itself. After a particular threshold level of the force applied, the alveolar bone permits tooth movement. How? By remodeling. So the alveolar bone itself can be a source of intraoral anchorage. Again, the basal bone. Areas of the basal bone offering anchorage are the hard palate and the lingual surface of the mandible. So examples of basal bone being a good source of intraoral anchorage are the hard palate and the lingual surface of mandible. Again, the muscles can also be a good source of intraoral anchorage. Example, an appliance like lip bumper, which utilize the tonicity of the lower lip muscles. The tonus of the facial and masticatory muscles they themselves can act as a source of anchorage. So the musculature itself can be a good source of anchorage. If you are asked, give an example for muscular source of anchorage. The most common appliance is the lip bumper, which utilizes the tonicity of the lower lip muscles. Then coming to the extraoral sources of anchorage, the word itself suggests that the source of anchorage is outside the oral cavity. Extraoral means outside the oral cavity. So the source for anchorage is outside the oral cavity. So examples, cranium being an extraoral source of anchorage. Which part of the cranium? The occipital and the parietal regions. Examples of appliances where we make use of extraoral source of anchorage are headgears, which makes use of face bows to restrict maxillary growth. So you have uh, headgears. We all know that usage of headgears comes under the category of dentofacial orthopedics. Our department, the full length name of the department is Department of Orthodontics and Dentofacial Orthopedics. So headgears comes under the umbrella of dentofacial orthopedics. So if you are using headgears, where is the anchorage source? Why you are using headgears? Headgears can be either used for restricting the maxillary growth, or it can be used to bring about protrusion of the maxilla. So if you are planning restriction of the maxilla, you can use the occipital and parietal regions of the cranium as extraoral source of anchorage, or also the cervical region, the back of the neck, can also be used as source of anchorage in cervical pull headgear. So let us look at this picture. The first picture is high pull headgear. Second picture is low pull headgear. And both are given for the same purpose or objective. What is the purpose and what is the objective? Both are used for restricting the excessive maxillary growth in a growing child. So you are restricting the maxillary growth. Then what is the difference between a high pull and a low pull? Difference is that the pull in the high pull is above the occlusal plane, and in low pull it is below the occlusal plane. And what will happen? And its effect is felt upon the maxillary first molar. So if you want intrusion of the maxillary molars, you use high pull headgear. Whereas in a horizontally growing patient where you need some amount of extrusion of the maxillary molar to bring about vertical changes, you give low pull headgear. Here in the first picture, you can see that the patient is wearing a headgear, and you can see a strap passing over his parietal bone and one passing over his occipital bone. So these two are the bones which are the extraoral sources of anchorage. What is it? Why you need this anchorage? To restrict the maxillary growth. As the Newton's third law says that for every action, there is an equal and opposite reaction. So when you give a high pull headgear, you are concentrating a restrictive force on the maxilla, and the source of anchorage is the parietal bone and the occipital bone. Whereas in this picture, it is also given for maxillary, restricting the maxillary growth. The extraoral source of anchorage is the nape of the neck or the cervical area. So but the difference between a high pull and low pull is that one is above the occlusal plane and one is below the occlusal plane. So again, the third set of bones which can act as extraoral source of anchorage are the facial bones, like the frontal bone and the mandibular symphysis. Example of an appliance is the face mask or reverse pull headgear. So look at this patient. She is wearing a face mask, or what is the other name for face mask? Reverse pull headgear. So what is the purpose or the objective of giving a reverse pull headgear? Reverse pull headgear is given to a patient with maxillary deficiency where your intention is to protract the maxilla. To protract the maxilla, you need to pull the maxilla out. So the resultant reactionary forces, the anchorage is derived from the, you can see the strap going over her forehead. Which bone is that? The frontal bone. And the extraoral source of anchorage are the frontal bone, and the mandibular symphysis. For what kind of appliance? A dentofacial orthopedic appliance like reverse pull headgear or Petit type or Delap or Pickham type of face mask. Now, the anchorage can also be classified according to the, so here we have seen the classification of anchorage depending on the sources. That is, it could be either an intraoral source of anchorage or an extraoral source of anchorage. Now, the anchorage can also be classified according to the manner of force application. It could be simple anchorage, stationary anchorage, or reciprocal anchorage. Simple anchorage. Maximum number of anchor units included to bring about movement of one tooth. Typical example is a removable appliance with a screw or a spring to move a single tooth. Anchorage derived from the rest of the teeth by extension of the acrylic plate. The very extension of the acrylic plate makes all the other teeth into a anchor unit so that you can incorporate a screw or a spring to facilitate movement of a single tooth. Now, coming to stationary anchorage, the bodily movement of one group of tooth is pitted against the tipping of other teeth. Here you can see that there is tipping of the anteriors, while as more difficult type of tooth movement, like bodily tooth movement, where entire translation of the tooth occurs. Then we have reciprocal anchorage, where the force applied to teeth and to arch segments are equal. So the force distribution in periodontal ligament is mutual and equal. For example, as this pictorial representation defines, the purpose is a midline diastema closure. So both these two force units complement each other. That is, they reciprocate each other. So one tooth will be the anchor unit for facilitating the movement of the other teeth. It's more or less like a reciprocal arrangement. So the distribution in periodontal ligament, force distribution in the periodontal ligament is mutual and equal. Now, we can also classify anchorage according to the jaws involved. It could be intramaxillary anchorage or intermaxillary anchorage. What is intramaxillary anchorage? Resistant units and the teeth to be moved are in the same arch. For example, we all know that this is an expansion appliance. So, if you draw a line in the middle, the mid-palatal suture, we all know that the one half will be the mirror image of the other. And the purpose of an expansion appliance is that the arch is contracted. You need to bring about an expansion of the arch. So, maxillary arch. So, for this segment, for this palatal shelf half, the other unit will be the anchor unit, and to facilitate the other movement of other half in the transverse direction, the other unit becomes the anchorage. So this here the reactionary unit and the resistant unit are in the same arch. That is why it is called intramaxillary anchorage. So an expansion appliance can be a good example for intramaxillary anchorage. Then you have intermaxillary anchorage or Baker's anchorage. Why it is called Baker's anchorage? It was put forward by a person named Baker. So in intermaxillary anchorage or Baker's anchorage, the resistance unit will be in one arch and the teeth to be moved are in the opposite arch. So anchor unit is in the opposite arch and the teeth to be moved are in the opposite arch. Example of such situations of like Baker's anchorage are class 2 usage of class 2 elastics in class 2 malocclusions and usage of class 3 elastic in class 3 malocclusion. Look at the first picture. Here, the patient is wearing the elastic in this fashion. What does it signify? What is the purpose? We need to the upper anterior teeth to move back, and the anchor unit is in the lower arch. That is a class 2, typical class 2 situation. Whereas Here we have a patient wearing elastics in this fashion, which is class 3 elastics. So the teeth to be moved are in the lower anterior segment and the anchor unit is in the upper molar. So these are examples of uh, intermaxillary anchorage. So recently, most of the research has found out that not only online classes, the virtual classrooms, the attention span of every human being is getting reduced. And the research has shown that the maximum attention span where you get some amount of good attention is only 20 minutes. So I think it will be better if I stop at this particular point in time and move on to a more of interpersonal discussion of what to find out what they have learned so far from this 20 minutes. Then only the purpose of imparting what has taught in this last 20 minutes will be useful to the student as such. So let us move on to a discussion on till the intermaxillary anchorage among ourselves. Okay.